Today, we're diving into a strange and frankly pretty terrifying medical mystery that happens at the very edge of life and death. It's called the ICU Paradox. Just imagine this for a second. You've fought for your life, you've been in the intensive care unit, maybe on a ventilator, battling some awful illness, but you did it. You pulled through. You survived. But then, as the fog of sedation lifts, you discover something is terribly wrong. You try to move your arms, your legs, and you can't. You are profoundly, shockingly weak. This is a terrifying reality for so many ICU survivors. And look, this isn't some rare one-in-a-million complication. The scale of this problem is, well, it's staggering. For patients in the ICU with a severe body-wide infection like sepsis, the chances of developing this weakness can be as high as 70%. And in the most extreme cases, when you have multiple organs failing, it can affect pretty much every single patient. So what is this? Well, doctors have a name for it: ICU acquired weakness. And really, it's an umbrella term for two things that can go wrong, often at the same time. Critical illness polyneuropathy, we'll call that CIP, and critical illness myopathy, or CIM. Okay, so to really get a handle on what's happening inside the body, we need to look at these two culprits. We need to figure out if we're dealing with a problem with the nerves or a problem with the muscles. Let's use an analogy, because it makes it way easier to understand. Think of your nerves as the body's electrical wiring, and think of your muscles as the engines they control. Critical illness polyneuropathy, or CIP, that's a problem with the wiring. The long nerve fibers that carry the signals get damaged. On the flip side, critical illness myopathy, or CIM, that's a problem with the engines themselves. The actual muscle fibers start to break down and waste away. Now here's the real-world challenge. While it's nice and tidy to separate them in theory, in an actual patient lying in an ICU bed, these two things very often happen together. And that creates this really complex, mixed condition where both the wiring and the engines are failing at the same time, making it so much harder to figure out and treat. So that's the what, but the really crucial question is, why? Why does being critically ill unleash this kind of devastation on our nerves and muscles? Well, the answer is basically a perfect storm of system failure inside the body. And you know, this is so complex that researchers are still trying to pin down all the details. This quote from a major review paper back in 2014 really sums it up. It's not one single thing. It's a whole cascade of things going wrong, from circulation to metabolism to the very energy systems in our cells. This chart looks complicated, I know, but you can boil it down to a four-front war being waged on the body. First, the supply lines break down. The tiny blood vessels that feed the nerves and muscles get all leaky, and that starves them of oxygen. Second, your metabolism just goes haywire. High blood sugar creates a toxic environment, and stress hormones start sending signals that literally tell your muscles to break themselves down. Third, the communication system fails. The electrical signals that make everything work just get completely disrupted. And finally, you have a full-blown energy crisis. The mitochondria, the little powerhouses inside our cells, they start to fail, and that leads to widespread cell death. So with all that chaos going on at a microscopic level, how in the world do doctors figure out what's happening? Well, it's a bit like a medical detective story. And believe me, the clock is always ticking. The investigation always starts right there at the bedside with a physical exam. But there is a massive roadblock right from the start. The patient is often heavily sedated, on a ventilator, just too sick to cooperate. I mean, how can you test someone's strength if they're not even conscious? So those very first signs are often completely missed. And even when the weakness is obvious, doctors have to ask themselves this really important question. Wait a minute. Could it be something else? Because there are other serious conditions that can look a whole lot like this. And getting the diagnosis right is absolutely vital. They have to rule out mimics, and the most common one is a condition called Guillain-Barré syndrome. You can see the differences here. A huge clue is the timing. Guillain-Barré is usually the thing that lands you in the ICU. But ICU-acquired weakness, well, that develops after you're already there. And this distinction is critical because the treatments are completely different. One needs supportive care, the other needs things like plasma exchange. So to get that definitive answer, they bring in the advanced tools. They can use electromyography, or EMG, which uses tiny needles to test the electrical signals in the nerves and muscles. They can even stimulate the muscles directly to see if the problem is the wiring or the engine. And then there's what's called the gold standard, a muscle biopsy, where they take a tiny piece of muscle and look at it under a microscope to see the damage firsthand. Okay, so once the case is cracked and the diagnosis is confirmed, what happens next? What does the path forward look like? And is there really hope for recovery?
The first thing to understand is there's no magic bullet here. There isn't a single pill you can take to make it all go away. Instead, the entire approach is a three-part strategy: prevention, supportive care, and most importantly of all, rehabilitation.
As you can see, it's a true multi-pronged approach. It involves everything from getting the underlying illness under control to very specific therapies designed to stop the damage and help the body start to heal. So let's break that down into the three absolute keys to recovery. Number one, you have to treat the root cause, the sepsis, the organ failure, whatever it was that started this whole firestorm. Number two, you have to control the risk factors. For instance, we know high blood sugar is a huge problem, and studies have actually shown that tightly controlling it with insulin can lower the risk. And number three, and this is probably the one that makes the biggest difference in the long run, you have to start rehabilitation, and you have to start it early. And we're talking about an active, aggressive process here. This means physiotherapy, starting with gentle exercises as soon as a patient is medically stable. It means early mobilization programs with the goal of getting patients sitting, then standing, and sometimes even walking while they are still in the ICU. And for patients who can't move on their own, they can even use electrical muscle stimulation to make the muscles contract, which helps preserve that precious muscle mass. But the road to recovery is not the same for everybody. This is a really critical point. A patient's future can look very different depending on what was damaged. The prognosis is often much, much better for patients who just have the muscle damage, the engine problem. They tend to bounce back quicker and more completely. It's the patients with nerve damage, that wiring problem, who often face the longest, hardest road back, sometimes dealing with weakness for months or even years. And that brings us to this huge central challenge facing modern medicine today. As our technology and skills get better and better, as we save more and more people from the very brink of death, we have to face the consequences of that survival. So the final question we have to ask isn't just about how we get patients out of the ICU alive. It's about how we make sure that the life they fought so incredibly hard to save is one that they can truly and fully go on to live.